My name's Peter Whitesell, and I have the honour and privilege to be the president of KCLEA and to welcome you to this inaugural lecture and to a reception along the corridor afterwards. There are going to be, as far as I'm aware from the health and safety point of view, there are no scheduled fire alarms, so if the fire alarm does go, out of that door and left or right. And I think the answer is that we convene either in the Strand or overlooking the Thames. Engineering has been here at King's for a very long time, perhaps not as long as some aspects of medicine, which has now taken part of the King's Foundation. Engineering has been, the Engineering Society for Students has been here just 9 years after the college was founded. You've got all the details in the handout. I think the one thing that we all feel, and looking around here at people that I recognise who are engineers, young and old, is the variety and the strength and excellence of what happens. But what is an engineer? If you look around you, everything that you see that isn't part of the natural world was the vision of an engineer. Every power station, every road, every railway, every bridge, every mobile phone, every airliner, every piece of equipment, and every sewage works owes its existence to an engineer. Great engineers have a passion to improve life, a burning conviction that they can make life better for everyone. Engineers need to have the talent for invention and innovation, but what drives them is the conviction that they can find a better way to do things, a cheaper and more efficient solution to the problems of human existence on this planet of limited resources that we call Earth. Not my words, but those of Prince Philip, Senior Fellow of the Royal Academy of Engineering, and he goes on. In addition to ambition, those who aspire to change the world for the better also need to acquire the skills and knowledge that the previous generations have bequeathed to the art and science of engineering. Engineering is not just a profession to be learnt and practiced in the way of making a living. It is one of the few ways that human talent can be given the chance to improve and frequently transform the comfort and prosperity of the human community. In fact, engineering has made a greater positive difference to human life than almost any human endeavour. And as an engineer, isn't that important? I would say that with engineering, the medical profession has caused the greatest change in the world in which we live. And isn't that actually what a university like King's does? Empowering people to go out into the world and make it a better place. I'd like now to introduce Professor Michael Luck, who is Dean of the Faculty of Natural and Mathematical Sciences, to talk a bit about what is happening now at King's. Michael.
Thank you. So let me just begin by saying that it's my great privilege to welcome you here to the KCLEA inaugural lecture. And it's my privilege because engineering has a very long tradition and heritage at King's, and it continues to be a very important part of King's. We in the Faculty of Natural and Mathematical Sciences see engineering as a critical part of what we do. This is something that we do today. It has always been here, and it is likely always to remain. We don't, at present, have engineering above the door of a particular department, except biomedical engineering, of course. But engineering from the Division of Engineering continues today in the Department of Informatics. Robotics and telecommunications, mechanical and electronic engineering continue today. And as I said, we also have engineering going on elsewhere in the Division of Imaging Sciences and Biomedical Engineering. And our engineering today is actually very, very strong. In the recent Research Excellence Framework, our submission to general engineering came 5th overall. It came 2nd in terms of impact, particularly relevant when considering the title of tonight's talk. In informatics, with our robotics and telecommunications groups, we came 14th out of 89 and 8th in terms of the power rankings. So our engineering is in the top 10 of the country. Okay? Next year, we are running new undergraduate programs in electronic engineering and its variants. And building on the success that we've had in the REF and the success we have with our current research and success that we hope we will have with our new undergraduate programs, in addition to our postgraduate offerings, so we offer several master's programs in engineering from within the faculty, we will be exploring new options. We will be trying to understand what we can do in terms of engineering going forward. With a new principal, there is a new effort to think about and to consider what King's should be doing as a whole. And some of the things that have been talked about include business and science more, and technology, including computing and aspects of engineering. So there's an effort to ensure that the tradition and the heritage of engineering at King's continues. And I think tonight's talk is a part of that journey, if you like. It's a connection between the past tradition, the heritage that we have, and also how we go forward. And I'm delighted to see so many of you here today, in particular because I think KCLEA is a critically important part of King's as a whole and of natural and mathematical sciences. Thank you.
Thank you very much, Michael. In June this year, it'll be 40 years since I graduated from King's. And just thinking back to why I wanted to become an engineer, that goes back a very, very long time. But let's take from the age of 11 or so, when I decided that what interested me was practical physics. So I applied and had an interview at Imperial College. That seemed to be very interesting because the Department of Electrical Engineering there seemed to be determined that electrical engineering was the only form of engineering that was worth doing, and all other forms of engineering should be rapidly dumped in the Serpentine. That wasn't quite what my attitude was. So my actual first choice, and I had an interview later here at King's. And what is there about King's that really attracted me? The key thing was that King's covered the whole gamut of learning, whether it is music, war studies, law, which I did on engineering, arts, science, theology, history, geography, the medics, all very interesting topics that if I was going to learn, I felt it was useful that I was working with. And I'm so pleased to see so many people looking down the list who have graduated in those topics as well as medicine and engineering, which is perhaps the focus for today. That is so much the spirit of King's. So I came here, actually, engineering was in those labs down in the basement. And I can remember sort of dark night like tonight, coming out of the basement, crossing over to the river and walking along the embankment and just looking over the edge and discovered that my feet were lower than the river. That doesn't happen nowadays because of a King's engineer, a chap called Ray Horner. And you might, a rising sector gate sounds incredibly boring. Thames Barrier sounds an awful lot more exciting. And there's almost pure engineering being used for the benefit of people. large. As president of KCLEA, the Student Society, yes, we had some quite interesting student things. Particularly at the time, as the principal was Major General Sir John Hackett. Yes, we lost temporarily Reggie, the college emblem, a fellow student who went by the delightful name of Hamish McNinch, went and recovered him. But Hamish's great achievement was to take a pram and some balloons from here along the Strand, which caused some degree of traffic chaos, cunningly run a rope round Nelson's column, attach the balloons to the rope, which had a cunning knot, which meant that a banner was seen at the top of Nelson's column which said, "Kings is great." And not only that, it appeared on the front page of 2 broadsheet newspapers the following morning. So what came out of that? I had John Hackett came and found me and said, "Let's have a celebratory drink," which I thought was a good idea. The Dean sent me a very, very nice note, and Speckled Branch came round. But it was those times at university that you begin to discover people that matter in our business. And we're here tonight in a theatre that commemorates Professor Kevin Nash. Kevin was associate principal of the college during my time, and even though he was one of the most eminent civil engineers, academic, and carrying the administrative load in the college, he always had time for the students, even a student like me that wasn't doing civil engineering. I don't know, the thing that I remember most about Kevin is his quiet wisdom, and that is really absolutely key to what he did. I spent my career in broadcasting. Actually, it's quite interesting to sit at home and listen on the radio to hear on the PM programme academics from King's speaking. The role of a university is far more than the research and the teaching of students. It should also be the imparting of the knowledge that comes from a place like this to the greater world. And you know, broadcasting is ideally that. In fact, I've worked to try and get academics on television, both technically and otherwise. Linked into tonight, I am now more or less running the UK operation of the Society of Motion Picture and Television Engineers, which is a mere stripling. It's only 100 years old next year. And that's a very strong link with tonight's topic, because we're interested in the quality of the image. How many of you have heard about 4K TV? You can buy one. David would do. That is what you can go, you know, what the consumer electronics industry is saying is the future of television. The way that they're doing it isn't quite, and I've spent the past 2 days lecturing here in London and Salford on the subject. But King's engineers have had a great place to play in 8K, even better, perhaps. The technology not of the next few years, but of the next decade. It's very pleasing for me to see Peter Calvert-Smith, who was been a member of my team for around 20 years, a long time, and John Zabriskie, who did a PhD here. The three of us were much involved in the first international transmission of super high vision, the 8K television from NHK, 2008. So 3 people in King's looking at the technology of the future and getting that to work. Also, not so pure engineering, Kris Wadsworth. He's a BBC VT editor. He was the VT editor on Blackadder Goes Forth. It is he who worked out how that series should end. Going slow motion, then to a monochrome, picture of a field which grew by going to colour the poppies. And when I went along to the Tower of London last year, that was the field of poppies there, resonated with me, the field of poppies at the end of all of that. And before I move too much further, can I also mark Professor Charles Turner, who guided us through these things, and not only that, is responsible for having a plaque on the wall outside which commemorates Professor of Natural Philosophy at King's College London, James Clerk Maxwell, whose equations are what makes modern electronics, radio systems and the other work. But from the past to the present, and to Liz. My notes say she was unusual as a student. Yes, I really got to know Liz as we recent graduates, and perhaps those I see now who are more senior and more established in their careers, were coming into King's to mentor students. A term alumni didn't exist then, but we were giving something to back to King's, as I and others are still doing in our activities and prayers, as King's has changed over the years. And in fact, it was very exciting for me to hear what Liz was up to, because the technology that she was working in hadn't really been invented then, and she was part of the thing. In her career, she has had many achievements, and I think we'll hear about some of them tonight, but in all of this, she has been here in King's, talking and working with the academics and the students in engineering or in medical sciences. So it's a great pleasure that I have to ask Liz Beckman to present the KCLEA inaugural lecture. Liz.
Good evening, ladies and gentlemen. Peter, thank you for that introduction, and Michael for the update on what is going on in engineering here at King's. I'm very honoured to have been asked and invited to give this, the inaugural KCLEA lecture, on a subject that impacts us all and is so very close to my heart, an area which I've worked in for most of my career since I left here in King's in 1974. The impact of engineering has done so much to help improve the ability of clinicians and others in medicine to diagnose and to treat patients. I doubt if there is anybody in the audience today who either hasn't had direct contact with some aspect of it or who knows somebody who has. But it is a huge and broad subject, a subject which I cannot do justice to tonight. All I can do is to give us a few tidbits. And I suspect that there are many people in the audience tonight who know far more than I do about some aspects of what I'm going to talk about. Engineering affects us in every aspect of what we do, and that is true as well in medicine. Medicine in the 21st century would not be what it is today if it wasn't for engineering. Every day we hear something. Only yesterday there was an article in the paper about a cancer breathalyzer. Somebody has invented a device which can actually look at chemicals and analyse them to detect chemical changes in the breath of patients or people who don't even know that they've potentially got lung or bowel cancer. So in looking at it today, I can only start to grab at some of the different areas which has been when engineering has had an impact. I won't even be able to look at all of these areas. I can look at some of them in a little bit more detail, and these aren't all the areas that are affected. But perhaps a place to start. Peter was talking a few minutes ago about the different aspects of engineering that have been here at King's? Well, perhaps one place to start is to look at different branches of engineering and how they have impacted in medicine. Even the stalwart in the days when Peter and I were here at King's of the engineering faculty was civil and structural engineering, and I suspect there are quite a few people in the audience tonight who came through that faculty. That has had an impact. It's helped to develop the buildings and the structures which so much of the medical equipment goes in. Even as we sit here now, there are 2 centres in the UK, one in Manchester, one in London, being designed to provide proton therapy. I hate to say that the one in London is up in, not far from Gower Street, as we used to call it, University College, otherwise known as. Mechanical engineering, the use and its help with prosthetics, with robotics. Chemical, well, perhaps let's look at one or 2 of these in a little bit more detail. Chemical engineering, the ability to create structures that can do vascular grafts, can actually go in and repair the vascular structure, repair and reinforce existing veins and arteries. They're often made from specialised polymers which have to be lightweight but very, very strong and need to be special materials. Stents which are put in to reinforce weak arteries in the body, made from specialised stainless steel alloys, again, have to be very strong and lightweight. Then there are the implants for spinal, for cardiovascular, for ophthalmic, made from a variety of polymers, from ceramics and metals. Artificial knees and hips. I wonder if anybody in the audience here has got an artificial knee or hip. I think there are some. Now made from biocompatible specialised polymers and surgical titanium. They have to be rugged, yet highly flexible. And I'll come back to some of the areas which have improved in that. Now, we can often get them made with 3D printing, which I will talk about a little later. But chemical engineers and material scientists are the people who create the very materials that enable us to make the 3D printing for this. The surgical mesh that you see there is made of naturally occurring biopolymer that has biochemically been engineered to maintain its strength until it's absorbed by the body after healing has occurred. Then perhaps looking at my field, I graduated here as an electronic and electrical engineer, and it's the area that I've worked in. But we know areas like intensive care monitors, all the measurement equipment, different types of instruments, all ranges of medical devices, from pacemakers like the St Jude pacemaker, so small. When I was younger, you wouldn't have been able to make something as miniaturised as that to be implanted to control the irregular rhythm of the heart. And so many other different devices. I'll come back to a few later. The field which Michael referred to, which exists here in King's, I'll come back to again in a little later. But what do we mean by biomedical and medical engineering? One definition is the application of engineering principles and design concepts to the human body, medicine and biology, and to a broad range of instrumentation used in modern medicine. It brings together technological innovation to the field of medicine and healthcare, and medical devices, but also the whole area of working with engineering actual tissues, genetic engineering, neural engineering, which is the relationship of neurons or neural networks in the body and nervous system functions. Often neural engineering has said that its main goal in medicine is to actually help restore and augmentation of human function via direct interaction between the nervous system in the body and artificial devices. For example, electrodes placed on the skin of a patient who's an amputee to interpret signals from the nerves in the body and to actually control the prosthesis. There are also brain-computer interfaces which can directly communicate with the nervous system to monitor and stimulate neural circuits for patients, for example, who have got Parkinson's disease. Perhaps one of the areas that's most obvious that's had a huge impact is the whole field of computer analysis and computer science. Taking basic images and creating what look like almost space-age images here. This fairly obviously is that's the head, we're looking there at the jaw, the neck, and down into the ribs and the thorax. That's created from a series of CT scans, which I'll come back to talk about in a moment, and actually stripped away layers of the image to just leave certain aspects of the vasculature that the doctor wants to look at. But that in itself and the whole area of imaging is my world. I've worked for most of my career associated to the medical imaging world. Well, we've come quite a long way since that famous first image of an X-ray taken in 1895 by Wilhelm Conrad Röntgen in Würzburg of his wife's hand that became so famous as the start of X-rays. But it's perhaps strange to think that although we have come a long way to the funny images that we can now create like that from CT data, that it was actually in the 1970s when CT, which was the first major step in imaging after Röntgen's discovery of X-rays, came about. The very first CT scan was done at Atkinson Morley Hospital in South London on the 1st of October 1971. And there you see the actual scanning table with Dr. Jamie Ambrose, the radiologist who was involved. But the whole technique of that we have to thank to Godfrey Hounsfield. Godfrey was the person who came up with the idea. And I don't have the time, fortunately, tonight to go into it in detail, but suffice it to say that this was his laboratory prototype. And he went straight from that to the machine that went into Atkinson Morley. But his prototype, which is nicknamed the lathe bed, is so called because he didn't have much money, he didn't have much budget. So he was continually going around and nicking things from other projects and from the laboratory. And he based it on the bed, the base of an old lathe, and hence it became known as the lathe bed. And here what you're seeing is the black area over there is an X-ray tube. That is a brain specimen he borrowed from a laboratory, and on the other side is a detector, which is detecting the X-rays which have passed through the specimen to create the image. I'm going to take a couple of minutes just to bore you with the basis behind CT, because I think it is interesting to note that it actually wasn't, it was a revolutionary concept, but it wasn't that complex in some ways. By the way, the name computed tomography comes from the fact that tomography, tomo is the Greek for slice, and graphy to write. So it was to write a slice with the use of a computer. And that's exactly what CT is. It is creating images of slices of the body. We use the principle of the fact that X-rays, when they pass through a material, are attenuated by whatever they pass through. The material absorbs some. So if you pass some X-rays through, you'll get less out. Pass it through twice as thick a material, you'll get half the amount out. Pass it through different materials, you'll get different amounts out. And if you take an X-ray tube and move it around the body, exposing and passing rays of X-rays through, detecting them on the other side, let's for a moment just think about a couple of those readings of X-rays. And in the early days, what they did was they looked at the fact that if you take that reading 1 and say that it has gone through a number of different squares, picture elements, pixels on the image, you can actually say that it has gone through the whole of square 4.1, about 4.2, 4.3, 4.4, 4.5. So it has taken, that reading there has taken across there, is due to the attenuation of each of those squares. Reading 2, on the other hand, going diagonally up there, is the whole of 110, half of 19, etc. And you get a series of simultaneous equations. I'm not going to challenge you to remember how to do simultaneous equations, but suffice it to say that if you have got enough equations for the number of unknowns, you can solve for them. And so you can calculate the value of attenuation of each of the individual squares. And that was the original basis of how CT was calculated. And from that, you can then give each of the values a grey shade and create an image. And what we found is that on a scale, which became known as the Hounds Field-Scale, air had a value down at -1,000, water was at 0, and bone was +1,000. In fact, we can now detect up to much denser bone, up to +4,000. And the important thing was that different types of tissue had different values. So abnormal tissue showed up as a different value or a different colour to that which was normal tissue. And so it had a huge impact on diagnosis. CT has come a long way. First, the early CT was all for head scans and was a small aperture machine. But the first body scan, which was publicly shown, was actually one of Godfrey himself. And he showed that at a Bermuda conference in 1975 and got a standing ovation from the doctors in the audience because they recognised the impact that would have on medicine. Godfrey, in fact, one of his colleagues, shown there, the shorter gentleman, Tony Williams, was in fact the first person to be scanned because he was small enough to fit into a head scanner. But I don't think that image still exists. But this is an important issue in terms of the fact that that team you see there was a multidisciplinary team. There was a mechanical engineer, there was an electronics engineer, there was a computer programmer, there was Kaglame, who's closest to me in the picture there on the right as you look at it, was the specialist in writing the algorithms to actually make my very simplistic solving of simultaneous equations far more sophisticated and far faster. Certainly the technology that went in was really quite complex. The gantries in the early days were very mechanical. There was a lot of mechanical movements going on and very complex making. Then you also had, in the more modern ones, there is my X-ray tube again, there are detectors on the other side, and this whole gantry is rotating around in under a second. So the forces and the movements, because the X-ray tube, well, I'm not sure nowadays I could lift one. I used to be able to, but I wouldn't like to guarantee I could now. And you've got it counterbalanced with very heavy lead weights. So the forces and all of the other influences that had to go in, as well as all the electrical processing. In this slide, you can see those cables going off, taking all the different signals off to the computers to process thousands and thousands of readings. There was also detector technology. Those are the detectors dating back to about 1980, 79-80. Those actually are cesium iodide crystal detectors with a photodiode mounted on the back, because the whole technology worked on the fact that the X-rays would hit the crystal would convert the X-rays into light, and the light would then be detected by the photodiode and converted into an electrical signal that could go off to the computer for processing. I show a space shot there because one of the interesting things in this time was that it is a good illustration of the switch of technology or the sharing of technology between different areas. The table there was a cantilever table because the patient needs to be able to lie right into the aperture of the machine, was made of carbon fibre, and it was a technology that had been acquired from the space programme. But in the same way, the space programme took a number of skills and expertise and knowledge areas from scanners like this, because the scanners had to deal with far more data than the space programme ever did. And I'll come back in a little while to some of the challenges of actually managing and coping with the data. CT was more than just a diagnostic tool for looking at straight images, such as patients who'd had accidents or cancer. It became far more. It became ability to be able to do guide interventional procedures, to be able to guide where a biopsy needle should go accurately, to take a specimen from a particular part of the body, to be able to analyse and do a pathology specimen to decide whether a particular area may be cancerous, may not be cancerous. That greatly improved the ability to know how to treat a patient or whether they needed which treatment might be best for them. Additionally, the ability to look at blood flow, angiography. But CT, this is an area which is still a challenge for CT. CT is much better now because we can get very fast scans. We can also pulse the scans, time them to be triggered by the different phases of the waveform in the heart. But even so, the heart and what's called peristaltic movement, which is the natural movement of the body, of the muscles and the breathing, really do distort the image. So this is an area which still remains a challenge to us. But even having said that, this was probably one of the greatest impacts of engineering in medicine in the 20th century. And for that, Godfrey Hounsfield was awarded the Nobel Prize in Physiology in Medicine in 1979. Another engineer and scientist, British, who was awarded the Nobel Prize in Physiology or Medicine in 2003 was Peter Mansfield. Peter was at Nottingham and he shared the Nobel Prize for his contribution to another form of imaging, magnetic resonance imaging. Magnetic resonance was not immediately a new technique in imaging. It had been used as a method, it was known then as nuclear magnetic resonance, for analysing chemical samples, all sorts of chemicals. But it's moved to create imaging, to give us images, really clear images of the body, was something that came in the 1980s, 90s. Here we're looking at something different. We're not dealing with X-rays, we're dealing with the fact that the body is 80% water. Water is H2O, so we've got lots of hydrogen in the body. You put hydrogen in a magnetic field and all of the hydrogen elements line up. Expose it to a radio frequency pulse, it knocks it out of alignment. Then, when you stop the pulse, they will come back into alignment, giving off a radio signal. If you detect that radio signal, you can use the loudness of the signal, if you like, and the time of the decay to actually create your images. Little simplified, but that gives you a feel for it. But a lot of the magnet technology, for example, in this, again, is British. The main manufacturers of magnets today is Oxford Magnet Technology. And that Oxford has been one of the centres of excellence for magnets for most of the time that NMR and MRI have existed. Oops, didn't mean to do that. There we go. So MRI, CT are two of the imaging that is used commonly today. X-rays remain, with angiography, a discipline within X-rays for looking at blood flow and blood studies. But also, there are other ones, such as ultrasound, nuclear medicine, and PET. And I'm going to just talk very briefly for a second about each of those. Ultrasound has had a huge impact. We know it very much for imaging of pregnant mothers to look at the unborn fetus. But there are huge other areas such as liver imaging and also Doppler ultrasound for looking at blood flow. There, the red and blue is showing us a different phase of the blood flow. The machines are very small and simple, and they all work using a probe that actually it can be put on the surface of the skin. It emits an ultrasound wave, and every time the ultrasound hits a surface, some of it is reflected and it can be detected. And that is what is used to create the image. Ultrasound is growing tremendously, particularly in areas such as musculoskeletal, for sports injuries and other areas. Again, a different area, nuclear medicine. Here, totally different again. We're here using the fact that we don't expose an external radiation, we introduce the radiation into the body. So here you can introduce in here a lung study where xenon gas is breathed in, or an area where a different type of chemical, radioactive chemical, such as technetium-99, can be introduced to produce images. But what we're looking at is the dark areas there. The dark spots are hot spots. They are where the chemical that's been introduced has been accumulated, and we're looking at those. But the images really are pretty crude. We can't really identify where those hot spots are, or whether they are due to cancer, whether they're due to, are they something we should be worried about or not. A development of that has been something called PET, Positron Emission Tomography, which is a development which has come in recent years. Here, again, there's a PET image of a whole body. We're looking there, that structure there is probably the liver, the spine, the white areas you can just see there would be the lungs. We're seeing the patient standing up. Here is an axial slice, a slice like, and that is a CT slice. That's the PET, positron emission. What we're doing here, unlike the nuclear medicine, is we're using a chemical called FDG, which is a glucose-based chemical, which goes to cancer. Okay, so what we can see, there's huge uptake there and two other hotspots there. But where are they? One of the great developments in recent years has been to use computers to merge the images, to register a PET image with exactly the same slice done in CT, and to give us the image that's at the bottom there. And there we can not only see the hotspots as these white or orangey areas surrounded by purple, but we can also easily identify. And this is in fact a case where, compared to the original PET, by doing this, it changed what's called the staging, or the actual prognosis and treatment for the patient. They were able to change what was done for this particular patient. The problem that all of this has given engineering, well, there are lots, but let's start with one to start with, and that is handling the data, handling the storage. When I started in this world, and many of you may remember, those magnetic tape reels, which were about this sort of size, and they would hold 20 megabytes, which in those days would have been 10 CT patient studies. Well, each CT study now is much, much more data, so that would not help at all. It wouldn't even hold one patient now. From there, we went to floppy disks, originally 8-inch, which were 360 kilobyte, to 5.25, and then 3.5, which were what, 1.44 megabyte? Still really very little. I can even remember those removable hard disk platters, about the size of an LP and that deep, I remember travelling, slight aside, I remember travelling with one in my suitcase to Brazil once with a whole load of CT images on it. But they were only 10 or 20 megabytes. Again, very, very little data. When you consider that a PET CT study for a patient, one patient, is 650 megabytes or more, that is not going to help us very much. You know, we're lucky now that a USB memory stick like that would probably hold, well, more than 4 gigabytes. And these, at 1 tera, are starting to give us something. But even so, it's really a storage problem. Medicine creates one of the biggest storage problems for data. It's true, I suppose, we have come a long way from when the images back in the 1960s when Godfrey first started were actually being stored on punched paper tape, and it took 9 days to process an image. In fact, before he used an X-ray tube and he used some nuclear medicine technique for generating it, took him 9 days to acquire an image. But computers have come a long way. They have undoubtedly increased. The computer that Godfrey actually worked on, Godfrey Hounds Field, before he did CT, was this particular one is an Emidec 1100, which went to Boots. But that would have been about the length of this wall. And that had less processing power than a mobile phone today. So techniques really have come, and certainly CT would not have developed in the way it had if it hadn't been for other enabling technologies such as the mini computer. When EMI and Godfrey Hounsfield, who was working for EMI, first looked at CT, they assumed that they would be using mainframe computers and that all the data from the few scanners would be sent back to them for processing. It was mini computers that could be built in that changed that. It also changed what we could do with the images. We could actually, even very early on, take an image like this, which is straight through at about this level, through the eyes. You can see the 2 orbits there, and that's the optic nerve. You could magnify the area identified in that rectangle to that area there. You could then say, okay, we've got a series of slices going through. So within that area, we can actually slice down, use the computer to slice, like slicing a layer cake, and slice down to actually see the impact. So here is our enlarged area on different slices, and then there is our vertical reconstruction through those slices. Because we're looking here to see what that white mass at the back of the orbit is, and also whether there's a problem with the optic nerve there. So this, again, was a unique way to be able to improve the diagnosis and the understanding and the information available to doctors. Image processing has moved a long way. I'm not going to show you very much. Again, this is some years ago now, but here, body slices, that area there we're looking at is the liver. The white area is the bone, the spine, and bits of the ribs. But having taken those slices on either side, we can then do a slice straight down through the body, and then we can say, okay, let's look at the whole 3D volume we've got. Let's remove all the soft tissue and leave ourselves with the pelvis, the spine, and the ribs, and then re-overlay certain structures we're interested in, like the kidneys and the blood vessels feeding those. And so we get a certain amount. But Peter referred earlier to the work being done on 4K TVs. Well, we give a challenge to displays, a different challenge, but we need 4K. We've needed it for a long time for things like breast imaging. It is true that we can zoom in, as I showed you earlier, and use a standard 1K by 1K monitor, but we really do want 4K by 4K for a lot of the imaging. but it's got to be high quality black and white, and it's got to be well calibrated. But then there are other things. Okay, so we use black and white for some of those, but then we have images we want like ultrasound or some of the 3D images or the PET-CT that want colour. So then there becomes a compromise, or how do we engineer to be able to do that? Often it comes down to multiple monitors because you want different information. And often doctors can't get, engineering still hasn't solved some of the problems, they still can't give them all the information they want on one computer screen. So the challenges still remain. There are lots of them. There are challenges for moving information. I've already alluded to the fact that the image data I'm dealing with here is very, very large files, very challenging. So even moving the information around the hospital becomes a challenge. When we start to want to move it to another hospital, that becomes an even bigger challenge. Not that long ago, back in the 1990s, we were talking about using ordinary modems to try and move information. Then we had ISDN. Then we started to get some of the networks. Bear in mind that often an application here is life-saving. An example would be where a hospital has a scanner. It has a road traffic accident victim, and the victim comes in, they do a head scan, they want to know what they need to do. Do they keep the patient there and observe them? They need specialist neuroradiological expertise. They need to be able to transmit that image rapidly to a specialist hospital. And back in the 1980s, 1990s, that, not that long ago, that was the challenge. And it was solved as networks got faster. But even then, you were often compromising with the quality of what you could transmit to get it there in time. Getting information elsewhere, not just within the imaging community, to other departments, and their needs for information, not just images, are substantial. We can look at all of the different areas, whether it be surgery, whether it be oncology for cancer patients, whether it can be other forms of therapy. There are a tremendous number of different areas. And what I'm going to do now is just take one or two to have a quick look at. Looking first of all at the whole area of the improvement with radiotherapy. Cancer patients are nearly always needing radiotherapy. Radiotherapy which uses a high energy beam to actually kill the cancer cells. But it can also kill normal cells as the beam passes through normal tissue. So the art is very much to make sure that the planning decides the best way to put multiple beams in to actually get a maximum amount of the radiation where the cancer is, while minimizing how much is on sensitive organs around the outside, particularly areas such as the spine and other areas. And this is where using CT scans to accurately define the area of the tumour, and then knowing how different tissues have reacted to ordinary X-rays, you can calculate from that how they would react to high energy X-ray beams. And so the area of cancer treatment and the planning of radiation therapy has been enhanced. Another area is the area of surgical planning. The changes that imaging and surgery itself have made are tremendous. But there is a challenge. When we talk about X-rays and radiologists spend their life looking in the old days at X-ray film, nowadays at a monitor. That's 2D. What I can see and what you can see up there are 2D images. But surgeons work in a 3D environment. They want to know what is behind a structure. They want to know whether there is something behind that if they cut into this, they're going to pierce an artery, or what is going to happen. They need that information, they need it in 3D. And their whole working space is different. And the way in which information has to be provided to them needs to be different. There also need to be, now that we've got computer-based systems, we can use them to help improve some of the accuracy of planning for procedures such as hip replacements. In the early days, when all we had was X-ray films, somebody would take a measurement of the size of the patient's hip and guess which prosthesis would be best. Nowadays, the computers can actually accurately plan which one, and as I'll talk about in a minute, even do 3D and actually 3D printing to customize the printing of an individual hip. But there is so much more information, just looking at the surgical world, that they need. They need more than the images. They need pathology information. They need to be able to look at waveforms from ECG, EEG, and a lot of other different pieces of information, all added together to create the information to give them the best opportunity to treat and manage a patient individually. And it's getting all of that together that is a huge challenge. Some of it we're making some huge strides with already. The ability to actually give surgeons information about images in theatre to improve their actual ability to operate. For example, here, a patient who was actually being prepared for surgery, a laser scan to identify known anatomical landmarks, and then to overlay the information from a series of images onto the actual patient's skull in the theatre, so that the surgeon can work out where the areas that they actually want to operate on are in real time while they're in there. But surgeons need to be able to also interact with that while they're in surgery. So that is an area where there is still a lot of work being done. Another example is here a patient where this was using MRI slices of data to actually identify an area and work out the best path to insert a probe into the brain while minimizing the amount of damage that would be done to the rest of the brain. And doing that, again, in theatre in real time. As I've already said, surgeons work in 3D. So creating true 3D images for them becomes critical, like this here of a 3D showing a kidney transplant. But also some companies, such as an American company called EchoPixel, are working on interactive holographic displays, where if you sit with a pair of glasses on, you can actually work, and the surgeon can work in 3D, moving their head around the object that they're looking at, that they're going to operate on, and with a pen to actually plan how they will be able to get in to do the operation. It really has had some impact. The other area that has great impact in surgery is robotics. Robotics such as units such as this, which is a Da Vinci unit, where the surgeon actually sits at a console and actually works with his hands on joysticks and tools to control the movement of arms in the patient. He can be some distance from the patient. In fact, the surgeon could be in a different country, could be somewhere else. The only challenge then is the actual time delay between his movement and the movement of the instrument at the end of the robotic arm. But it is something which I know, I'm not aware whether our military used, but I do know that the American military has used this sort of technique for operating in the armed forces field. The applications of this are well established in some areas, such as brain and in prostate. Brain in particular is relatively easy because you don't need the tactile feedback. One of the problems of this is that the surgeon is at the end of instruments and hasn't got the feel of what the actual tissue feels like while he's operating. And many of the surgeons I know who particularly work on the abdomen say that they tell whether the tissue is normal or abnormal by its feel. And not having that degree of tactile feedback is a challenge to robotic surgery. But some of you may have come across about 2 weeks ago now the announcement in the press of an operation on a 58-year-old woman at the Royal Marsden Hospital for colon cancer, and using again here 2 consoles with a patient-side cart, a cart that sits alongside the patient, which had 4 arms. Each of the 2 surgeons was controlling 2 arms. And they were going in by very, very small incisions. It saved having to open the patient up from the rib cage down to the belly button. And it reduced, post-operatively, reduced pain, reduced blood loss, and really shortened the time for recovery for the patient. This particular device, which has a vision system, as they call it, which can sit in the operating theatre, so everybody else in the operating theatre can see what's going on within the patient's anatomy. They're seeing the same view as the surgeons are who are operating. But also, it has, on the end of each of those arms, it has got the ability to put different instruments. Instruments which can actually clamp, that can suture, can manipulate the tissue. And they've got a very quick release to be able to change those during the operation. The system there really this is the first one, I believe, in the country. And this is one of the first operations that's been done with it. Another challenge, which was an interesting one, is when you've got robotic surgery, fine. The surgeons are away from the patient. If they're touching the computers, it doesn't matter. But when you've got a surgeon who is actually operating, how does he control the computer to change the image that he wants to see? I want to go back. And the answer is hand signals. And there's been some work being done with the Microsoft Xbox Connect to actually be able to instruct computers to change images just by hand movements, so that they don't have to touch the keyboard, the mouse, or the screen. And that is another area where it has greatly improved the ability of surgeons to be able to get information that they need to improve their treatment and operating without having to say to one of their nurses, or to an assistant, and, can you change that, please? When we talk about patients, but once they've been operated on, and in other areas, the amount of monitoring that has to go on for the patient is extreme. All of the different monitoring, whether you're monitoring the blood, the breathing, heart rate, is all monitored, and all monitoring systems. The amount of change that has come with that over recent years is also a tremendous amount, whether those are for intensive care, intensive therapy units, or whether they are for special care baby units for premature babies. Perhaps one of the earliest monitoring systems was ECG, electrocardiograph, where the first ECG, first human ECG, was done in 1872 at Bart's Hospital by Arthur Muirhead. His father actually started a company in South London called Muirhead's. But it's certainly had a great impact. And I actually had a letter from an ex-King's graduate who couldn't be here tonight, Harold Beck, talking about his work when he was at Cambridge Instruments in the 1950s, working on 3-lead ECGs. But ECGs have come a long way. We're now talking of a machine which is no more than about 9 inches or a foot in square, but they still perform the same thing. They give a trace of the actual heart performance, and they enable doctors to be able to identify whether the heart rhythm is regular, irregular, and look at where the problems might be. But these are these now, the modern ones, are so portable that they really have changed the medical treatment. Another example of engineering in medicine is another story from a couple of weeks ago, which shows here a heart about that size, where you can see the hand holding it. That was a 3D model created by a gentleman called Dr. Tariq Hussain at King's of a baby's heart, when they were trying to plan how, in a very young infant, they would be able to repair the hole in the heart. By creating the 3D model, they were able to actually see in real size where the defect was, and to plan the best way to be able to do the repair. I'm glad to say that from what I've heard in the press, I think it's a 2-year-old now, Mina, is doing very well. But that makes me come on to 3D modelling. 3D printing. 3D printing is something that's been around since the 1980s. Initially it was done for rapid prototyping, but now 25% of all 3D printing is actually done for final parts, whether it be for aircraft parts, for medicine, and for others. 3D printing is really an additive technology where you print in layers. And I suspect there are some people in this room who have far more experience than me. But suffice it to say that it is now being used for everything from aircraft toilet parts, when a toilet breaks on an aircraft that is in a Far East. Instead of flying out a spare part, they just send the dimensions and the details so that a part can be printed in 3D locally. There is a number of different techniques. There's extruding through a nozzle, rather like icing a cake, where you can extrude everything from plastics, metal, wood sawdust, even clay. There's stereolithography, where you can actually create an individual layer. This was actually invented by Charles Hull in 1984, and you use a laser to trace patterns, solidifying the pattern in each layer as it goes. There are a number of different similar techniques to that. The problem with this, although it can do very fine layers, is it's expensive. Then there's binder jetting, where you can actually spray a layer of glue, then add powder, add more glue, then more powder, using heat to fuse the powder at each layer. You can also binder jet metal using stainless steel powder, although currently it's not considered good enough to be used for aircraft. But in medicine, 3D printing in medicine enables us to create things like personalised hip prosthesis, far better suited and with far less problems of rejection or complications. You can make individual parts from scan data, and they create one or two off for low cost. It also means that you don't have to have a stockpile of different types of hip prosthesis in a hospital, costing a lot of money and taking up space. There are even areas like this that I'm showing at the bottom there, which is Novogen MMX, who put down bioink spheroids. They grow them, then put a layer of biopaper, then they put another layer of biospheres, and then they merge together, creating finally living tissue, roughly in the right place and of the right cells. But this is still very much early days of trying to create a real living 3D image model. But there are other areas where it's being extensively used. Before 3D printing, implants, particularly for things like face that's a jaw there and a face with a spine at the back there, were being used by milling machines. And there was one, again, forgive me, at UC up the road. But now they're done by 3D printing, done from data, from CT data to build replacement parts. The only problem is, although we can at the moment use lots of different materials to make 3D models, we can't use bone. Bone is still not a good material, and therefore this is a titanium jaw. It's done on a patient, an 83-year-old woman, whose jaw was completely removed because of progressive disease, and this was the replacement titanium part with a 3D model of her bone structure to check it before it was actually put in place. A lot of work done on dental. In fact, a lot of people are already wearing 3D printed temporary teeth. It's very common. Customized hearing aids, 90% of those are 3D printed. Optical frames, I think if I had mine done by 3D printing, they'd probably fit a lot better than my current ones I'm wearing. Hip implants, as I've already talked about, titanium. In Japan, a company called Phasotech are doing a lot of 3D models for teaching, for medical teaching and for teaching students. The area and the spectrum of work that's being done with 3D printing is significant. There's also the whole area of bionics, which is the study of the properties and the functions of the human body system, and the area of actually creating spare and replacement body parts which have been damaged by injury or disease. A couple of interesting examples here. Bespoke fairings there, they specialise in doing specialised coverings to surround an existing, for example, prosthetic leg that can actually give a customised shape and feel to the actual leg shape to make it look far more natural. These can not only be, they can be personalised, they can be and individual. Then you've got the Osteo Cast for a broken arm, which can include therapeutic pulsed low energy, pulsed ultrasound to help speed up the healing of the actual broken bone. All of these are using imaging to generate them, so you'll forgive me for having spent quite a lot of time on imaging earlier. But they use different materials, and they are using 3D printing. There are so many areas as well where we look at the dream for the future of 3D. One dream that somebody publicised recently was being able to scan their face when they're in their 20s, store it, and have a 3D mask created every 20 years or so. There are very many, including the ability to ultimately create 3D printing of organs for organ transplant replacement, because we have a drastic shortage of replacement organs for transplant. But there are challenges for the future. There are general challenges in medicine. After all, the population is ageing, and we're also expecting a higher quality of life, or demanding it, for longer. So there are more sophisticated things that medicine can do, but at a cost, and it needs innovative, high-tech solutions that are cost-effective. Technology is also often looking for applications. In my world, there aren't many, there are not that many new developments coming, but there are a lot of technologies out there that haven't yet found whether they really fit in and have a medical application. There are also, well, clinical needs, there are so many. Improvements for hearing, for sight, even for spinal repair. Organs for transplantation, I've already talked about the shortage there. The specific challenges of tactile feedback for robotics are just some of the few. Materials that we need, the new materials that can be used in the body for whether it be for printing, for implants, for whatever, that we need that are non-toxic, that are strong, that last a long time and are good for wearing. We need to get an improved accuracy in the techniques that we're using, including in 3D printing and in robotics. Engineering is about problem solving, and these are certainly some of the many problems that still need to be solved. One of the things I'm delighted about is what we've already heard this morning or this afternoon, and that is the fact that King's has a number of areas. Not only does it have the biomedical engineering arm in the imaging sciences and biomedical engineering faculty, offering its degrees and extensive areas of research, but also now, under Michael, we've got the new engineering programs in the Department of Informatics coming with exciting opportunities, not least there, I've been talking about robotics and robotics. I hope that in the last 45-50 minutes, I've given you a start of some of the areas where engineering has had an impact of medicine and the challenges which lie ahead. But in concluding, I'd like to leave you with a couple of thoughts. Firstly, some of the greatest engineering innovations in medicine have been done on a minute budget. As this cartoon, which was drawn by Tony Williams, one of Godfrey Hounsfield's engineers, shows. It's amazing what can be done with a hacksaw and micrometer. And sometimes they're often done by people with little formal engineering training, and perhaps, rather like Godfrey Hounsfield, who are defined when they're at school as being intellectually retarded. Thank you.
Thank you very much, Liz. I've now got time for a few questions. Anybody? Tony.
I'll try and stand. This is a view from the other side of the screen, you understand. I have to say, as we've gone through this evening, I ticked so many of the boxes, I'd better be brief. You know. I'm afflicted with things called aneurysms, which are very nasty. They sneak up on you and kill you. Now, it is not long ago that a major aneurysm here or down there, the surgical procedure would be 6 to 10 hours, something like that. You stood at best a 50-50 chance of getting off the table, 3 or 4 weeks recovering, 9 months recovering at home. My operation 5 years ago took the surgeon about an hour, and I walked out the next day, got a taxi and went home, and played golf 2 weeks later. I was being cautious. But the beauty of the thing is, the surgeon actually required less skill than the surgeon had required 10 years earlier on. And the advance was purely engineering. Absolutely engineering. Engineers, thank you for keeping me alive.
Thank you, Tony. Let me go to the back here.
I wanted to ask a question. It's not a pure engineering question, but it's related. You touched on implants at the start.
Yeah.
And I wanted to ask if people are already thinking about the information security aspect of that. I know it's really pedantic, but there was it does seem to be quite a large problem. People, for example, with the Da Vinci machines, talking about going over the internet, it's very open to sort of hacking techniques. And the same with the infusion and the pacemaker.
Certainly in this country, I won't say we are perfect, but on the whole, the requirements for security over data transmission I was heavily involved with a company that was involved in moving PET-CT data all around the country, and we had very tight security. In fact, the images did not have any identifiable patient name or details. But I'm not saying it's perfect. But there is some attempt at controlling it, yes.
Perhaps I should stand up. My name is Dave Bancroft. I'm a personal beneficiary of the advances that engineering has given to medicine. 10 years ago, I was diagnosed with a pituitary adenoma, and a big one. So that was surgery within about 24 hours, which saved me certainly from blindness and possibly from worse. So 10 years ago, and I'm still doing pretty well. Now, so thank you to all the wonderful people who made something possible 10 years ago that 10 years prior to that probably would have done me in.
Yep.
What I would ask for next is real-time blood monitoring. So critical things like sodium level, osmolality, and so forth, things like that. And that to be coupled to an implanted nano dispensary of my prescription drugs, so that I don't have to remember to take the pills. The dispensation of the amounts is in relation to automatic monitoring of feedback endocrine hormones, so you preserve the loops. At the moment I'm running open loop, and sometimes I fall over because it doesn't work correctly and there's blue flashing lights, etc. So to avoid that inconvenience, I'm looking forward to a couple of advances.
There's certainly movement going on, not necessarily, and there are some challenges, as you'll appreciate, because some of the blood monitoring you can't actually analyse instantaneously, but if you just take, for example, patients with type 1 diabetes, there are now infusion pumps which they wear, which is used, but again, they are tending to prick themselves, read them, make the reading and type it in to be able to actually then ensure that the right amount of the drug of insulin is being given to them. But there is a lot of work being done, but you're right, there's a lot more.
Thanks very much for a very interesting lecture. My area of interest is in abdominal organ transplantation, and two of the problems we have is in patients who require redo surgery, there's a lot of scar tissue inside the abdomen. And the second problem we have is in pediatric transplant, where we have a lot of vascular anomalies, which makes implantation quite difficult sometimes to isolate a vessel. And those beautiful pictures that you showed preoperatively of the anatomy superimposed on the patient prior to performing the surgery, is that a dynamic model or is that a static model? That's the first question. And the second question I have is about 3D printing of organs and the organ shortage. Could you elaborate a little bit more on that?
Sure. In terms of the model, it depends on which system you're talking about. Some of them can do, bear in mind that a lot of the overlays are from previously acquired image data sets. So in that respect, they would be static. But there is a lot of work being done on being able to acquire images interoperatively that you could then analyse in real terms and overlay it at the same time. So there's work being done on actually identifying anatomical landmarks, so that you can, even if it is a historically gained data set, those landmarks can morph with the actual movement of the real patient. But as you say, particularly if you've taken the images some days or weeks before, the size of the abnormality you're dealing with or the organ you're trying to transplant or some of the structures may have changed, and you're dealing a lot with a lot of peristaltic movement and other that will change the area. But there is a lot of computer work being done on that, tremendous amount. To take your second question, the whole area of 3D printing is really very, very new. When you think that the Stratis full 3D machine, I think is only, colour machine is about a year old, and 2014, I think it's February 2014. There really is a lot of work being done on that. And I can't claim to be an expert, but I think it is something that will come. But there's so much work to be done. but we're going to need it if we're going to cope with the need for organ transplantation. And that's a field that I've been in all my life. So,
any more?
A quick one.
Yes.
yes, Charles.
Do you think that wearable electronics has a role to play in
Yes.
medicine?
Very definitely. There's a lot being done now with home monitoring, where patients can actually wear some monitoring equipment that is actually feeding information through. But there's also the whole area, as I said, of whether it be a pump or some other form of electronics that can monitor something and can actually alert or treat the patient there and then. But there's a lot of work still to be done in that. Is that the sort of area you were talking about?
Yes, or even clothing itself, to have
Oh.
it integrated into.
Well, it's rather like the device I showed, which was the splint for treating a broken arm, where they've actually got into that pulsed ultrasound. But there will be more in clothes. But again, we come almost back to the question that was asked earlier about the security aspect, and that is Big Brother world almost. You know, if we wear something and allow information to be being transmitted, where do we end with it? That's probably another discussion in itself. There was another question.
Right
Yes.
back there.
Go.
All right. I hope I'm talking loud now.
Fine.
I have a couple of questions. Actually, one of them is pretty small, and I'm just curious about the Da Vinci machines, if they're actually used also to educate new surgeons, like a new generation of surgeons, because I find that it might be a very interesting for the new surgeon to actually see the viewpoint of the expert one, and I think it might be interesting in that regard. So perhaps they maybe record what the surgeon sees and what he does, so later on a student surgeon could learn from that. I'm wondering if they're actually doing it. Another one might be quite controversial in some regard, especially in the engineering, people engineering, myself being a software engineer. But question regarding how far engineering should go in terms of longevity. Like, as you said, the population is aging, right? And it involves spending more money and, all the things around. And I would like to hear your thoughts, as you said, you've been working in engineering since, 1974 when you graduated. And I'm curious from the perspective of the engineer working for quite a long time in the field, what are your thoughts on that? Like, should we kind of stop at some point and limit ourselves as engineers, or should we let the thought fly forward and let the other people think about it?
Okay. I'll try and remember to answer both questions. Going back to your first question, remind me the key point of that.
The student surgeons
Yeah.
learning.
Yeah, what is already in existence, I don't know how much Da Vinci are involved, but there is already a lot being done by the Royal College of Surgeons of England, in London and in Edinburgh, where they have dummy models that people can actually operate on, and they relay the information from that electronically to trainee students, surgeons. But what I don't know how much the Da Vinci information is done, but I would suspect that it's something I'm sure that they're looking at and will be using. I don't know. In terms of your second question, it's an interesting one overall, because the one thing that I've seen through my life involved in engineering and medicine is the fact that people are living longer, that more and more sophisticated engineering techniques exist for improving or prolonging life. And the question is, we can't afford them all. We might be able to afford, and I'm not talking in terms of engineering, I believe engineering should keep investing in trying to improve things, because the more it does, the more it's likely to create something that's more cost effective, and therefore will actually take the overall cost down. I think the issue of how much we can do for everybody, for medicine, at what cost for what benefit, is a huge ethical question.
that perhaps is a very interesting and thought-provoking note on which to try to bring the formal proceedings to an end. All I can say is that I am very pleased that I now know some of what was going on last week when I was invited to stuff my head in one of those machines for an MRI scan. The interesting thing was, of course, that this outside the machine said Siemens on it, which they provided the funding for the chair in electrical engineering here, and actually were my last employer. I'll call upon Graham Raven, my predecessor, the past chairman, the president of KCLEA, to say a few words.
Thank you, Peter. Excuse me wandering around. There is a practical reason for it, which you'll find out in a moment. My first job is partly to answer one of the questions. In fact, I was fortunate enough to be operated on, in fact, this time last year, on a Da Vinci machine, and part of tonight, I now understand a bit of the surgeon's report, which said screen time, 2.5 hours, or I thought, what the hell was that about? And now I now understand. But also, there was 17 minutes training time included in the... I hope that was at the end of the operation and not at the beginning. I'm here, so that's fine. The primary job, of course, is to thank Liz for coming to us tonight and explaining in personally the right amount of detail for me. I'm a civil engineer. In fact, it's very nostalgic. The first person I met at King's 55 years ago was in fact Kevin Nash. He interviewed me, and I'm pleased to say he let me in. But I'm a civil engineer and I'm a beneficiary of this sort of work. So, and the other thing is, thank you all for coming. I'll come back to Liz in a minute, because this was a bit of an experiment. As you know, it's the KCLEA's first annual lecture, we hope, and it was a bit of an experiment, and I'm actually delighted to see the range of people, ages, talents that are in this room. So first of all, thank you all for coming. But then moving on to Liz, thank you for giving us such an interesting talk. I think it's, you know, from the attention, clearly it struck many chords, and there's many people in the room for different reasons thankful. But I'd just like to give you a little memento of the occasion.
Thank you.
So thank you very much.
Thank you.
And thank you for setting such a high standard for our annual lectures.
Thank you very much, Graham. Can I just sort of put on public record your contribution to keeping KCLEA determined and supportive of King's throughout the past few years, when engineering has not been as preeminent as it has in the past, and as we would hope it would be in the future here. And also to our whole committee, perhaps particularly to Kris Bowden, who as secretary keeps us under control, to Mike Clode, whose links with the students and his determination to help us memorise the more recent history, and to Keith Newton, who produced, we haven't got it here today, but about a 20-metre long banner showing the history of engineering at King's, and he has done so much to get our social activities up and running, and to Ted Willis, who's taken that responsibility of organising our events, and of course Joanna from the alumni office, who ensures that everything gets printed, we all have labels, and everything gets organised. The whole subject of multidisciplinary work, which is what is needed, is so important and tied across all sorts of disciplines. We've heard topics tonight which have not been either in pure engineering or pure medicine, coming to law, ethics, the history. And I think what we have heard tonight from Liz has given us a great education, the drawing out, when actually so much of what she has been talking about is looking in at our bodies and how they work. So thank you very much, Liz. Thank you all for coming.
Thank you.
It's been great having such good questions, such attentive audience. And would you please thank Liz, and then please join us for a drink just along the corridor here, because we would like to find out about your background and to hear your reasons for coming here tonight. Thank you all very much.
Thank you.